think so. So want to introduce for Dr. Leon. So this is our grand rounds that we are presenting from the Neurodevelopment Intervention Science, IPC. And within this IPC, we've been focusing on early childhood development of social emotional communication, early literacy development. And so we're really excited to have Dr. Leon, who is coming from the University of Miami at the Coral Gables campus in the Department of Psychology with their BCBA program. And one of the things that we've been building in the partnerships within the LEND training is to bring in the master students within the BCBA as we try and expand and support for those children with autism spectrum disorders and other neurodevelopmental disorders and the intervention side to that. And so we're really excited to have Dr. Leon here, and I'll turn over to her to go ahead and let us know a little bit more about her background, what she's going to be presenting on today. So thank you, Dr. Leon.
Hi, thanks, Michelle. Thanks everyone for having me here today. Like Michelle said, our program recently kind of joined in the LEND training program, which I'm super excited about. I'm going to talk a little bit today about best practice in applied behavior analysis. Really, my main focus for today, what I hope that you all take from it is really what a good ABA would look like. So that you all can have a framework for understanding that when you work with your own families. In general, I think we all know that working with individuals with neurodevelopmental disorders requires a really truly interdisciplinary approach. So I hope to shed some light on where ABA and BCBAs can fit into that. After speaking with some of the other LEND faculty, I have really tried to put a framework together for the general context, and then I have some time for questions at the end, because I suspect there may be a lot of those. So before we get into it, just a little bit of background on me. I'm a Miami native. I'm super happy to be back here in Miami. I did my undergrad at the University of Florida. I was a psychology major, and that's where I was first introduced to applied behavior analysis, where I worked in a self-injury lab. I then went to get my master's at UMBC, which is a small school in Baltimore, while I worked in the neurobehavioral unit at the Kennedy Krieger Institute. There, I worked in an inpatient unit that did assessment and treatment of severe behavior disorders. I stayed on for a little bit doing some research on relapse there. And then I did my doctoral training at FIT, where I worked at the Scott Center for Autism Treatment, where I continued to do some work in behavioral assessment and treatment, and then also on some organizational behavior management, which is, I guess, the behavioral side of IO psychology. In terms of my professional background, after I graduated, I took a visiting assistant professor position at FIU. I then moved on to FIT in their professional master's training program, where I was for 5 years. And then I joined early 2019, where I teach in the master's program. We supervise practicum students at our IBIS clinic. And I also have an affiliation with CARD in their applied research and behavioral training division. So I present this general background just, over the last 10 years or so, my primary work has been in training master's level behavior analysts who work with individuals with neurodevelopmental disorders. Okay, so applied behavior analysis. What you're going to see here, this is kind of the textbook definition. It's the science in which tactics are derived from principles of behavior applied to improve socially significant behavior. And also experimentation is used to identify the variables responsible for the improvement in behavior. If you Google it, that's probably the definition you're going to get. I'd like to provide a little bit more background kind of on the historical the trajectory of applied behavior analysis. Applied behavior analysis is, can be separated now into what a discipline and a profession. The discipline is, it's a scientific discipline whose subject matter is individual behavior. So, behavior analysts are really interested in behavior at the individual level and how that interaction with the environment leads to the development, maintenance of any individual behavior. And within the discipline, there's theoretical, experimental, and applied branches. So historically, applied behavior analysis, that term was used to really describe applied researchers in behavior analysis. There was not a huge distinction between the discipline and the profession until very recently. More recently, we have seen a huge growth in the profession, and I'll show you guys some data on that in the next few slides. By definition, the profession of applied behavior analysis is just probably where you have interacted with individuals who are BCBAs. It involves the design, implementation, and evaluation of some instructional or environmental modification by the behavior analyst to produce some socially significant change. So it essentially takes the data from the discipline, the experimental and applied research base in application in a practice setting. And in practice, this is blended with other disciplines or other approaches. For example, there's a lot of training programs in behavior analysis that are housed in special ed departments. There are training programs in behavior analysis that are housed in clinical psychology training programs. There are some programs like ours that the behavior analysis program is independent from the others. So, we've seen as the profession has grown, we've seen kind of a hybrid approach to training behavior analysts that really kind of depend on the institution in which those training programs are held. And then this has generally led to, kind of a variety of different flavors of ABA. And I'll get into that in a few slides also. I just wanted to note that, again, there's this historical connection between the discipline and the practice. Historically, the practice was really done within the context of university training programs. There weren't a lot of professionals who were doing ABA just for the practice. They were researchers and trainers who kind of incidentally did practice. Now, what we've seen in the last, now 12 years is a huge increase in the profession of applied behavior analysis. So what is displayed here, this is a recent job growth graph that was set forth by the BCBA. So these new data just came out, I think, like 2 weeks ago. And it shows from 2010, which coincidentally to when I was certified, so this little data point right there, to today, these new data, 2021, you can see just this huge increase in the demand for behavior analysts. So what you see here is years across the x-axis and number of job postings that are requiring a BCBA across the y-axis. And since 2010, there's been almost a 6,000% increase in demand for BCBAs. So, the profession of behavior analysis is just really kind of increasing exponentially. We can talk about this a little bit in the Q&A after. This is obviously driven by lots of things like insurance funding for applied behavior analysis practice, increasing rates of autism, and just the field growing in general. But there is, especially over the last 5 years or so, this really kind of exponential growth in demand for individuals with a BCBA certification, as behavior analysis has moved from only to now a discipline and a profession. I point this out just to kind of set the context for some of the growing pains that I think the field is currently experiencing. So it's a really exciting time, I think, for behavior analysts, but also there's some challenges that we're facing as a field in terms of training and supervision because of this increase in demand for behavioral professionals across the board. So next, I want to just go over a little bit of the requirements for training and credentialing. This is an area where I feel families often and other professionals don't really have a framework for understanding who the players are in the behavioral team, what their jobs are, what they should be doing. So this is an area where we really, via CARD and via our ABA program, are trying to really educate families and other professionals so that they can have a context for understanding who should be doing what does good ABA look like, and really just some red flags for helping families understand if they're not getting the care that they should be getting from their behavioral team. So the Behavior Analysis Certification Board was established to really just establish the professional credentialing needs. So it historically was an international accredited or certification body. Now they are not doing international certification anymore, only national. And they certify practitioners at multiple levels. So the BACB credentials recognize practitioners at 4 levels. With a high school degree, an individual can become a registered behavior technician. I'll cover this again in a few slides, but this is essentially the person that is doing the direct delivery most of the time of therapy. Then at the bachelor's level, there's a board certified assistant behavior analyst, or BCABA. This is a position that historically has not had a huge demand. For one reason or another, Florida has always had more BCABAs than other states. And now some other states are utilizing the BCA a little bit more, but because of insurance funding, there are some states that do cover the service and some that don't. So this might be one where you encounter these as part of the care team, but it's not an essential part of the care team. It's like an extra set of eyes, essentially. The master's level certification is the BCBA. And this is the one that you may be most familiar with in your work if you're working with individuals who have a behavioral care team. And then at the doctoral level, it's the BCBAD. So these are the different levels and credentials of certification that are recognized by the BACB. Just in terms of language, practitioners that are credentialed at the BCBAD and BCBA levels are defined as behavior analysts. BCABAs and behavioral technicians are not independent practitioners. In fact, they cannot be independent practitioners. They're required to work under the supervision of a BCBA. Just as a general note, one point of confusion that I've seen with families, for example, is the role of the BCABA or even the role of the behavioral technician. Some agencies or organizations will use the broad term analyst to refer to all of their behavioral providers. This ambiguity, I think, sometimes makes it hard for parents and other professionals to understand the role of individuals in the team. So, one thing that I would always recommend when working with families is to make sure that they understand that there, at minimum, should be 2 people that are part of the team. The behavioral technician, who is the general implementer, and then the BCBA, who's the supervisor. And I would encourage them to not use that broad term of analyst, because that ambiguity, I think, sometimes makes it hard for them to understand who should be doing what. One thing that I always tell my students is that so again, they need the degree, the coursework, and the supervised experience. Once they have all of that, they take their board exam, and if they pass, they can then practice. But this really just means that they've met the minimum practice standard, right? So we don't expect for BCBAs to be experts the second that they have graduated and passed their exam. I think there's sometimes, because of the high demand for BCBAs that we see out there, we see very young, unseasoned, I don't want to say just young, unseasoned BCBAs who maybe don't have the requisite training outside of their practical training programs to carry a heavy caseload. So these are some issues that we're seeing, particularly in Florida and in South Florida, where although you have individuals who are credentialed to practice, they may be taking on a little bit more than they should. So again, just a kind of general framework that this is the minimum practice standard. A little bit later on, I'm going to talk about scope of practice and scope of competence. So the board really just sets the general scope of practice for the discipline, but the individual behavior of individual BCBAs might vary based on their scope of competence. So behavior analysis and ABA typically employs this tiered service delivery model where you have a BCBA or BCBAD who supervises a number of registered behavior technicians or behavior technicians. Now they can supervise those directly, as you see in this top left example. If a BCABA is involved, they would be inserted, somewhere between the BCBA and the RBTs. The role of the BCABA here would be to help with providing additional support to the registered behavior technicians by way of modeling good interventions, assisting with sessions as necessary, but their role should not be in supervision. Right, so if you see the general colors, there's the blue and the green. The BCABA, although the word or the term might look more closely related to the BCBA, their role is more closely related to the RBT, and that they would be involved in direct service delivery and really providing support for the RBT, and they should not really be involved in planning or supervision. That's the job of the BCBA. I want to take a quick minute to talk about licensure. So as in most other disciplines in the helping professions, there are not just certifications, but licenses. In behavior analysis right now in ABA, there has been licensure laws passed related to the practice of applied behavior analysis in 33 states, which are displayed on this map here. You can see that Florida is one of the states that has not yet been able to pass a licensure law. So FABA, who's the state organization for behavior analysis, has, over the last decade or more, had several failed attempts at getting licensure laws passed. It is a high priority for the organization moving forward. But Florida right now is one of the states that does not have licensure requirement for behavior analysts. So what this means is that there are, of course, the certification standards by the board, the national certification standards, but there are a number of different disciplines that can practice and bill for applied behavior analysis services without specific training in applied behavior analysis. And we've seen this, particularly in South Florida, to be a big issue where of course, historically there are clinical psychology programs that have trained individuals in behavior analysis and even other master's level programs. But unfortunately, what we've seen in Florida, particularly in South Florida, is there are a number of other professions that have been able to set up what they refer to as applied behavior analysis practices, but they don't have the requisite training and credentialing. But because there's no licensure laws, the BACB has had a hard time regulating this. So again, I want to put that out there just as a general context for understanding some practice issues as it relates to applied behavior analysis in South Florida in particular. We see lots of agencies and organizations that have opened behavioral practices and are claiming to provide applied behavior analysis services without a BCBA certification, without any BCBAs on staff, and really without other appropriate requisite training. So a little bit about the role of the behavior analyst in supervision. In general, ABA treatment requires comparatively high levels of case supervision to ensure effective outcomes. And this is an area where I think people from other disciplines sometimes are surprised at the level of supervision that we tend to require. And there's a few reasons for that, right? So one is there's an inherent individualized nature of treatment. So I'm going to go over that in the next few slides as it relates to the types of interventions that we tend to implement. But because most of the interventions are very individualized, it does require a lot of oversight. Again, the use of the tiered service delivery model also is one of the reasons where we require a high rate of case supervision. The individuals who are delivering the therapy are not experts in behavior or experts in behavior analysis. They are following a treatment plan that has been written by someone with expertise in behavior analysis. Typically, the number of hours of intensive therapy that are needed are very high. And so there's a lot of repetition built into the treatment plans. So we can kind of leverage the fact that we have a lot of entry level kinds of clinicians that are doing the service delivery and the therapy delivery. But any changes, any developments of the protocol, those are not driven by the behavioral technician or the RBT. Those are driven by the BCBA in a collaborative team with the behavior tech and with the family, of course. Data-driven decision-making, so we collect lots of data, and then also the need for adjustments to the treatment plan. Again, just kind of tying back to the historical ties between the discipline and the practice, because the ABA model really was born out of universities, a lot of the practice standards were initially set based on research standards. So what would meet the single subject research requirements that were often a core part of these research programs. And the practice grew out of that. So that kind of tiered supervision model and the tiered service delivery model really kind of was born out of the fact that a lot of the practice was done within the context of ongoing research programs in universities. A little bit more about the role of the supervising behavior analyst. So the BCBA, or the supervising behavior analyst, has responsibilities with respect to supervision in two areas that are interrelated, but may not always go hand in hand. So there are clinical and programmatic supervision requirements, right? Clinical related to the client and the case, and then programmatic related to the supervision of the staff. So the supervising behavior analyst really needs to have a good sense of all of those, of the client functioning, the client skills, the client progress, and also the skills that their behavior technicians have or don't have, and how they can acquire those in a relevant way to be able to provide the service. So the BCBA is responsible for all aspects of clinical direction, supervision, case management. And this includes activities of their support staff, including the BCABA and the RBT. So for both BCABAs and RBTs, they're required to have what the BACB calls a responsible certificate. So they are tied to a BCBA, and the professional behavior of a BCABA and an RBT essentially can impact the ability of the BCBA to maintain their certification. In addition to that, the BCBA should have knowledge of each member of the treatment team's ability to effectively carry out clinical activities before assigning them. So again, in terms of just assessing their staff's scope of competence, the BCBA needs to not only keep tabs on how the client is doing, but of course, how the RBT or the behavior technician is doing. And then they must be familiar with the client's needs and treatment plan, regularly observe the behavior technician implementing the plan. Again, another note, a BCABA cannot practice independently. So even if a BCABA is involved in the case, BCBA supervision is required for both the BCABA and the RBT. Standards of supervision, again, as it relates to clinical implementation and also programmatic implementation. So the clinical standard of care is 2 hours of supervision for every 10 hours of therapy. This is clinical best practice. In addition to that, there are programmatic requirements where an RBT, in order to maintain their status, need 5% of all of their RBT hours supervised per month. And this has to be documented and reported to the board on a monthly basis. So the 5% requirement is a requirement to maintain certification. And then the clinical standard of care of 2 hours of supervision for every 10 hours of therapy is clinical best practice. So that is not necessarily tied to maintaining their certification, but it's a research-based recommendation for the involvement of the BCBA as part of the care team. So before we get into the specifics of ABA and the treatment of ASD, I try to make sure that our families and other professionals understand that even though the RBT is the person that is going to be the one that is most in contact with the child, is delivering most of the therapy, if the parent and the caregiver does not know who the BCBA is, or does not have a BCBA in their house or in their clinic at least every week, providing one-to-one supervision for the RBT, that's a major red flag, right? So at CARD, we often get calls from families that need additional help with their treatment. One of the first questions we ask is, are you working with a behavioral provider? They say, yes, we have an RBT for X number of hours that come per week. And then we ask, okay, how does the BCBA want to handle this problem? And some of the families don't know who the BCBA is, has never seen them, right? So these are major red flags. I would say if you have a family that is coming in to seek additional support from any one of you, and they are letting you know that they have not seen a BCBA, or the BCBA is not really involved in supervision, their only point of contact is the RBT, then I think that would be an appropriate time and place to give the family some feedback on the agency that they're working with. And perhaps it might not be a good fit or really kind of ethical practice for that. So an ABA, as it relates to the treatment of autism spectrum disorders and other neurodevelopmental disorders, there's some guiding philosophical principles that I think you're going to see, cut across all of behavioral programming. So the first really is that all behavior is functional, even if it does not look functional from the outside, right? The individual's engaging in some behavior because it is working for them in some way. They may not be engaging in some other behavior still because of a functional reason. So, the functional approach to understanding behavior is fundamental to behavior analysis. The functional analysis of the relations between behavior and the environment. There should always be attempts to understand why a behavior is or is not occurring before attempting to change it. All programming should be objective, meaning we employ direct observation and measurement. Again, if you're working with a behavioral provider, they should be able to provide data really on a number of goals and targets, because direct observation and measurement is at the heart of behavior analysis. And then lastly, one of the guiding philosophical principles is that it's pragmatic. We focus on individual behavior and contextual environmental factors and things that we can change. There are a lot of things about the individual that we cannot change. We cannot change their genetic history. We cannot change their behavioral history. We cannot change, a number of, issues related to the home environment. So it's a very pragmatic approach on how this individual is functioning in the environment, what are contextual variables that are leading to these behavioral excesses and deficits, and how can we change those contextual environmental factors to modify either whatever antecedents or consequences are relevant to produce some practical and significant change. The pragmatic philosophical underpinning of behavior analysis really is critical in driving the selection of programs and targets. This is another area where I often receive feedback from families, other behavioral providers, other service providers that they see individuals working with a behavioral provider for many hours per week. And the kid may not have any functional communication. They might not be able to ask for help or ask for a break or use the restroom. And yet they're doing a lot of table work on academic type skills, right? This is antithetical to behavior analysis. In general, a good behavioral approach will take a very functional and very pragmatic approach. Again, one of the things that we try to instill in our students all the time is so the selection of goals and how that is going to affect or influence this person's life next month, next year, in 5 years, right? And the goals might change. So you might have some goals early on within the context of the early intervention, which I'll talk about in the next few slides, that should and can evolve over time. But these guiding philosophical principles should cut across all of those goals, right? The functional approach of behavior, the continuation to very objective approach, and pragmatic and practical responses above all. So listed here are some essential practice elements of ABA. I'm not going to necessarily read those, but I've got some my own emphasis in the italics and the side. So in general, all ABA programs should start with an assessment that guides the selection of treatment. Treatment goals should not be just picked willy-nilly based on whatever is easy to teach. There should be an emphasis on understanding the current and future value of the behavior, right? So again, this focus on functional skills. Establishing small units of behavior. I think this is really an area where behavior analysts can shine with respect to being part of an interdisciplinary team in assisting in breaking down more complex behavior into smaller units in a way that is easier to teach, easier to learn, and easier to practice. Again, direct data. So coming back to being objective. To design, establish, and manage the social and learning environment, again, being very practical, linking back to function, carefully constructed, individualized, detailed behavior analytic treatment plans that are written such that anyone can pick it up and replicate it. Ongoing and frequent direct assessment, analysis, adjustments to the treatment plan. And then direct support and training of family members and other involved professionals. At its very nature, ABA should be collaborative. Parents should be involved. We don't want to turn parents into therapists, but parents should have a general working understanding of the goals and how their own behavior can influence the child's behavior, and they should certainly be involved in the selection of goals in a way that is culturally sensitive and significant to that family. And then, of course, as I mentioned before, a comprehensive infrastructure for supervision. So because of that tiered delivery model, an infrastructure for supervision is essential to a treatment plan. So there are two general treatment models in ABA that are referred to as focused or comprehensive. Focused treatment models involve treatment that is provided directly to the client for a limited number of behavioral targets. This is generally not restricted by age, cognitive level, co-occurring conditions. And this is likely appropriate for individuals who might need treatment for a limited number of key functional skills or some acute problem behavior that may temporarily take priority over other goals. For example, if an individual is having significant challenging behavior, even if they're in a more broad therapeutic context, there might be a specific intervention that is assessed or evaluated to reduce those barriers, to decrease the significant challenging behavior before they can move back into their more broad therapeutic environment. Some considerations when implementing these focus plans. A focused plan should be in place if there is a behavior that threatens the health or safety of the client or others, or constitutes a barrier to quality of life or inclusion. For example, severe aggression, self-injurious behavior, property destruction. These should be addressed in the context of a focused intervention. Similarly, if there's the absence of some developmentally appropriate adaptive, social, or functional skill that is fundamental to maintaining health or increasing independence, like toileting, dressing, feeding, compliance with medical procedures, these again should be addressed in a focused intervention. And I'm going to come back to what focus means as it contrast with comprehensive intervention. So I think what most people probably think about when they think of ABA is an early intensive behavioral intervention, which takes a comprehensive approach. Comprehensive ABA typically involves treatment of multiple affected developmental domains. So there are targets related to cognitive functioning, communication, social, emotional, adaptive functioning. Within this context, maladaptive behaviors can also be targeted, although they are typically targeted indirectly here. So here the focus is on skill building across multiple developmental domains in an attempt to build a behavioral repertoire that is going to be less sensitive to noncompliance and tantrums. But oftentimes those maladaptive behaviors are not necessarily the focus of a comprehensive intervention. A comprehensive intervention approach typically ranges from 20 to 40 hours of treatment per week in a therapeutic setting. Initially, this treatment model involves one-to-one staffing, a lot of direct work, and then a gradual plan to include small group formats as appropriate. Some examples of typical program components, particularly for young children with autism or neurodevelopmental disorders. listed here related to, again, social communication, independent functioning, play skills, imitation, the foundations of learning, right? Within early intervention, the initial focus often is, teaching the kid how to learn, observing others, learning how to imitate, learning those initial functional communication skills like asking for help, asking for attention, asking for a break, learning to play functionally with toys, learning to connect and engage with family and other coping and tolerance skills. So these are all targets that are often found in comprehensive ABA programs that, again, will be modified time as the individual acquires new skills. Now, within those, there can be a number of variations within those models, right? So the treatment programs within any of these models can vary along several programmatic dimensions. For example, the degree to which they are primarily provider or client directed, right? So you may have heard of structured versus naturalistic ABA, discrete trial teaching versus natural environment teaching. It's not that any one of these is better than another, right? These should be selected based on the individual skill. For example, discrete trials are really helpful early on for a child that does not have, a lot of very strong listening skills. They might be easily distracted. Showing them a book that has a number of pictures on it might not be an appropriate way to teach them how to label items. So early on, a discrete trial in a kind of sterile-ish environment might be the most appropriate approach, with a move toward a more naturalistic approach. On the flip side, if you've got an individual that has really strong foundational skills, sitting at a table in a sterile environment is really not getting that kid anywhere. A more naturalistic approach might be beneficial at that point. And many of these can be blended and should be blended based on the individual's kids' needs, what the targets are, and of course, what the family is looking for in terms of overarching goals. So decisions about how these dimensions are implemented should take all of these variables into account, right? What the research shows is effective, the age and the placement of the client, the specific target behaviors, how they're progressing, what prerequisite skills they have, and of course the resources that are required to support that implementation. So if you have an individual who is in a clinic-based setting and one-to-one, they may be able to have a more comprehensive program. Whereas if you have an individual who is in a preschool setting, maybe with a shadow for a couple hours a week, they may not have as comprehensive or as individualized approach. And then finally, you can have a blend of the comprehensive and focused, right? So I think most individuals receiving ABA therapy today are in the comprehensive model. That certainly is where practitioners are mostly being taught. But as other issues arise, for example, if a feeding issue arises, or if an individual has a significant challenging behavior that arises, the comprehensive approach can be essentially paused to include a focused intervention plan for that particular target, and then reintroduce back into the comprehensive model. So these two models can be blended. So to kind of start to wrap some of this up, what I've described so far is what we would generally refer to as the scope of practice of behavior analysis. So the BACB task list, the state licensure laws and certification describe the scope of practice in which credentialed or licensed behavior analysts may engage, right? What are the things that you can do as a behavior analyst? This is used to refer to the activities of the profession, and it's determined by external oversight or organizations. So that's kind of like very big picture. What can behavior analysts do? Now, scope of competence is used to refer to the activities of a specific individual. It's determined by the individual practitioner. And this can vary based on a number of things, right? So you may have an individual who has a lot of experience working with individuals in early intervention in comprehensive plans, but may have never done a focused intervention for problem behavior. You can have an individual who's worked really well in clinical settings, only with behavior analysts and families, but has never worked in a school-based setting and does not have a working understanding of special ed or how they fit into that. So, as you all are practitioners and clinicians working with these families, I think that's another thing to kind of understand and try to help families understand that they may have, they may start with a behavioral provider in early intervention. They get a new diagnosis, the kid is 2 or 3 years old, they go through a comprehensive treatment program. But as their child's needs evolve, it could be that their current care team is no longer a good fit. If their primary treatment is comprehensive early intervention, now what the family needs is focused, targeted intervention on adaptive skills or functional life skills, for example. So the scope of competence really is something that is going to be related to the individual provider. I will say as an aside, just on what we've seen with the growth of behavior analysis I showed in that early slide. I think early on, most providers were trained in both comprehensive and focused approaches. What we're seeing more and more of, which is primarily frustrating for me, is this shift in scope of competence where most behavior analysts are trained in early intervention and comprehensive treatment models, and very few are trained in focused interventions and more specific or targeted intervention models. So families sometimes are frustrated because they probably rightfully think that if they have a BCBA already, that BCBA should be able to take care of everything that they need. But the truth is that oftentimes it's just not in their scope of competence. And at that point, they may need to be referred out to another provider that does have that scope of competence outside of comprehensive early intervention. So some other just brief closing remarks. ABA has been successfully implemented in a number of settings. Oftentimes this may vary depending on funding sources. So, home-based care is pretty typical, school and community, clinic or outpatient, and also residential. There are a number of hospital-based programs that have employed behavior analytic treatment teams. This seems to be a problem in South Florida. We've been talking to a few inpatient and outpatient units across South Florida that are having a hard time getting their services billed. They want to bring behavior analysts on board, but haven't really been able to do that. So again, this is where the differences between certification and licensure are coming into play. If you have individuals working in a hospital unit, they may be expecting that only licensed professions can work there, and the credential really doesn't mean much. So there are some variations in how this is done across the country, but in general, both comprehensive and focused interventions have been implemented in all of these settings. Some other questions that we sometimes get is client age, right? When do they age out of ABA? And again, I think this really depends on it's a comprehensive or focused intervention. So the practice guidelines are that treatment really should be based on the clinical needs of the individual. They should not be constrained by age. Consistent ABA treatment should be provided as soon as possible. There's a wealth of research out there on early intervention and how significant exponential progress can be made when intervention is started very early. But ABA has been applied across the lifespan. We've seen a huge increase recently in job support, employment, preparation, self-care skills, living skills for individuals who are adolescents or young adults with autism. So in general, ABA is effective, can be effective, I should say, across the lifespan. And there's no research established guidelines that suggest any kind of age limit beyond which ABA would be effective. Finally, as it relates to collaborative care, again, ABA in general should be part of an interdisciplinary team. I always tell my students and other providers that we work with, I think where behavior analysts really can shine in an interdisciplinary team is in the how to arrange effective learning environments. ABA at its core is about learning and how individuals learn and really assessing that at an individual level. What to target may and likely maybe outside of the scope of practice. For example, in an interdisciplinary team, if you have individuals from speech, OT, PT, they have expertise in what the targets are, and they have their own approach, of course, for how to arrange that. Where behavior analysts, I think, can really fit in to that collaborative care model, maybe in assisting with individualized learning plans to improve motivation during those sessions, right? Oftentimes, individuals in a speech, OT, or PT session, they're working on really hard skills. They're working on things that are difficult, effortful, things they can't do readily, right? Otherwise, they wouldn't be there. So really leveraging environment to improve motivation, limiting maladaptive behavior during those therapy sessions. I think as providers, reaching out to the BCBAs on the team, they can provide hopefully good insight into how to improve motivation, how to arrange the learning environment as these individuals learn, to really maximize the time that they're in other therapy sessions. And then, of course, the importance of consistency in teaching procedures across sessions and environments. So I think the behavior analyst really can assist and shine in that arranging of the how, even across the other disciplines. Here I have just some organizations that are reputable and important, I guess, to know. So ABAI is the organization that backs the science of behavior analysis. APBA is the Association for Professional Behavior Analysts, and they set the practice standards. The BACB, of course, is the credentialing body. In terms of, for families to know, we've been trying to really disseminate these two. So the Council of Autism Service Providers and the Behavioral Health Center of Excellence. These are organizations that certify agencies based in their practice and clinical care. So I think those are two good ones to look at. If the agency is a member of one of these, then that probably is a good thing as opposed to not. So that is all I have. We've got about 12 minutes for questions. So I will open it up.
As we're opening for questions, people are welcome. They can unmute and ask questions you've got, or you can put questions into the chat.
Hi, good afternoon. I have a question.
And Yanni, could you stop sharing your screen?
Yes, hi, good afternoon. I have a question. So my question is, I need clarification on the age limit for receiving ABA for children under the spectrum. I was under the impression it was until the age of 22 where they emancipated. So can they receive services after 22?
Yeah, so there are two answers to that question, unfortunately. One is, can they receive services? And that is yes, and it can be effective. The other question is, will insurances reimburse for services? And that is a different question. So I think that is going to depend on the insurance funding and the provider. Most adults with autism continue to receive care through APD waiver services and other mechanisms that is not the funding that typically covers early intervention services, for example. So as with a lot of practice of medical care, I think it's a two-sided question of can you do it and who's going to pay for it? So yes, they absolutely can. And if they need, they should receive services. But I think the funding that would cover that would depend on their placement, the targets that are being covered, and the particular insurance and what part of the med waiver or not.
Okay, so if they're part of the med waiver, depends. But what about long-term insurances since they're emancipated?
If their individual insurance plan covers it, it may. So this is, it depends, and I hate to say it depends, but it depends. It depends on what their individual, so what we see is even within insurance plans, there are different negotiated rates and different negotiated umbrellas of coverage. So it depends on their plan and their provider. Even within, so even, one insurance carrier might have different negotiated rates and umbrellas with different providers. If you have questions about that, so if you have an individual who is an adult who needs this, you can always refer them back to CARD, and their CARD clinician can help identify an appropriate funding mechanism for them if there is one available. Jeff, you've got your hand up. Go ahead.
Thank you, Yanni. That was really wonderful. It's exactly what we needed to have a better understanding of the profession, how it fits in. So a question that often comes to me is a family will say, my child is biting, he's pulling hair, his behavior is really out of control. And I'll say, oh, great, you're getting ABA. What has the team suggested? And they're often at a loss. And I guess the question is, what should be our expectation for when the RBT is not there? And the parents now it's after dinner and the child's having some challenging behaviors. How does a BCBA or RBT help the family know what to do when they're not there?
Yeah, that's a great question. So, the family should be involved in the process from the beginning in terms of selecting targets and, really setting the stage for what is important for them. They should be involved from the beginning. We've parent training, parent coaching, however you want to call it. They should be involved in learning about how their child learns, how their child should respond. This comes back to this issue with comprehensive versus focused. Again, what we're seeing is a fleet of new ways that are hitting the job market that have a lot of training in comprehensive early intervention. That is what their training program taught them. That's what they're able to do. They do that really well. And then there are these kind of overlaying maladaptive behaviors or other things that tend to pop up that should be done in a focused intervention plan, but the BCBA doesn't have that training or background. They think they can just handle it by bombarding it with more goals from their comprehensive plan. But really the standard of care there should be pause some of these comprehensive skills, focus on whatever maladaptive behavior is happening, teach the parents how to do it so that it's being done across all settings, and then reintegrate back into your initial plan. So this is a gap. There's a research to practice gap. This is a training issue. But I would let the families know that they should, I think demand is probably a strong word, but, speak to the BCBA about the need for that focused plan. Does that answer your question? Okay, Christina says, how can we create more collaboration between disciplines in the care of the individual? I love it. So, number one is this, which we're here. There's, again, I think speaking from the BCBA perspective, because we're such a young discipline, I think number one, other disciplines may not even know about us yet or what our role is or how we fit into this, right? I think oftentimes a kid, for example, that is newly diagnosed might be referred out for speech therapy. I'll give a quick anecdote of a private client I had recently. It was a young kid, 2 years old, in the process of getting diagnosed, very clear speech delays, very clear social pragmatic delays. Was referred to speech language pathologist is working with them already. And then the SLP reached out to us because the kid doesn't have some of those requisite skills, like sitting down, looking, attending, right? So she reached out to us and said, this kid needs ABA at least a little bit before we can effectively work with them. I feel like I'm wasting my time in my session. I know exactly what the goals should be, but some of these prerequisite skills would be better taught outside of this very focused speech environment, right? So we went in, we worked on some of those pre-learning skills, a little bit of imitation, orient toward the person, instructional control, and then they reintegrated back into the speech. And we've been working really closely with the SLP there on increasing motivation in the session to really maximize that time. So, I think programs like LEND really are fantastic. I'm just so excited to be part of this because I know, it takes a village to raise a kid. It takes a village to do any one of these things. So I think just being aware of every discipline's scope of practice and how they kind of fit in together is going to really be helpful. I don't know if anyone else has comments on that.
I have a question.
Yeah, go ahead.
So we work in PCIT with kids with a variety of diagnoses of disruptive behaviors. It sounds like a lot of ABA and a lot of the experience I've had working with ABA providers is with kids with an ASD diagnosis. But I've definitely had some children who have other diagnoses who've received referrals for ABA.
That's a
what
great
are
question.
your-
I think that goes back to the first question of the day, which is a difference between what and how can ABA be effective and who's going to pay for what. So a lot of the driving, ABA has become almost synonymous with treatment for autism, which again, historically it was not. ABA is the application of learning principles to change behavior across a variety of domains. Because of insurance funding for ABA and the number of hours that often are prescribed, we've seen a huge increase in this demand for the profession. And then it loops into the opportunities for training are in autism because that is where the clients are. So we have an explosion of a workforce, but a workforce that is very narrowly trained in this one area. Which is unfortunate because historically applied behavior analysis has been used across a variety of different domains. It's funny because I work at CARD, but I always tell people I'm not an expert in autism. I'm an expert in problem behavior. That's where my training is. I've always worked with individuals with intellectual disabilities. I incidentally now happen to work with individuals with autism a lot just because of the nature of kind of where we are as a discipline in insurance funding. But absolutely, if you feel like an ABA referral is appropriate, an autism diagnosis is not required for ABA treatment. It may, again, be required by some funders for insurance coverage. So that's where there's this like, what can we do and who's going to pay for what?
So it sounds like you'd also recommend that the parent make sure that the training is there for working with that diagnosis as well, that the training is predominantly with children with ASD.
Yes, if that's where.
Okay, awesome.
I know we're running out of time, Michelle. I want to make a quick comment because it's really important. We're seeing this across a lot of clinical scenarios, and Yanni and I have talked about this. And Yanni, it was really helpful to hear that there's sort of the early intervention, comprehensive approach to ABA, and then the sort of the focused for specific maladaptive behaviors or positive social behaviors later on, and that not all BCABAs have that same level of competence, clinical competence. And I think it's really important for everyone here to hear that, yes, in some circumstances, a young child with severe autism, that comprehensive approach is exactly right. But if you say a 6-year-old with problematic behaviors with or without ASD, it may be that there is an ABA provider who has that training and he is used to dealing with sort of focused behavioral issues. But if that family then finds a comprehensive early intervention person, that's going to be a big mismatch. And you helped us really understand how that's so important to make that clear connection. So thank you.
Yeah, and I think those are all questions, that families can ask providers when they are connecting with them, right? How do you address these individual issues? Do you only provide comprehensive models? I think those are important questions to ask.
There's a question now in the chat that I want to make sure. We just have just a minute left. I want to make sure if you've got a chance to see that, I can read otherwise. It was about how is the field addressing feedback from neurodiversity advocates and autistic adults who are concerned about negative impacts of ABA?
Yeah, thank you for that. So that, there's we can probably have a whole hour talking about this. I will say that they are, all of the organizations that I showed have included individuals with who have neurodiversity or autism on their boards. There's a growing number of autistic adults who have become BCBAs recently, who are kind of leading the charge on this. So I will say that in general, the field is receiving that feedback. And I would love to talk about that more. Maybe we can have that be another summer grand round.
Well, thank you, Dr. Leon. I really appreciate you coming in to be able to, present us today and give us this bit of, kind of introduction. I agree. There's lots that we have to kind of move forward and lots of other training opportunities that we'll be able to collaborate on.
Okay. Great. Thank you, everyone, for having me.
Thank you.
Bye.
Bye.